Hello, I am Dr. Gary Gibbons, and this is a Society for Vascular Surgery briefing about preventative care and education for diabetics. Diabetes is a cardiovascular disease affecting 8% of Americans, or about 24 million people. It is increasing in epidemic proportions at greater than 1% per year. At another 58 million people with prediabetes who can control their getting overt diabetes through diet and exercise. 1 in 7 U.S. healthcare dollars is spent on diabetes and its complications. Diabetic foot problems are common and are estimated to affect 15% of all diabetics during their lifetime. More than half of the lower extremity amputations are performed on diabetics. Amputation rates increase with age in males and among members of certain racial and ethnic minorities. While the risk factors for developing peripheral vascular disease, PVD, are the same for diabetic and non-diabetic people, diabetic PVD is more common, occurs at a younger age, advances more rapidly, and has roughly an equal male-female ratio compared to non-diabetics. To establish preventative education and care for diabetics, one must understand the triopathy of their disease that uniquely puts them at higher risk for ulceration, faulty wound healing, and potentially amputation. Neuropathy includes loss of protective sensation, proprioception, motor nerve impairment affecting the skeletal and intrinsic muscles, and autonomic dysfunction affecting all major organ systems. Macrovascular occlusive disease, PVD, can affect any artery but has a predilection to occur in the tibial peroneal arteries between the knee and the foot. However, the foot arteries, dorsalis pedis and posterior tibial branches, are commonly spared, an important concept supporting aggressive revascularization to heal extensive tissue loss. Microvascular dysfunction begins early in diabetic life. It is not an occlusive lesion and results in endothelial dysfunction and loss of many of the vascular-related autoregulatory reflexes, response, and functions necessary for normal wound healing. Diabetics frequently manifest an abnormal response to infection. In addition to the loss of many of the required regulatory and reflex functions mentioned above, there are cellular and humoral abnormalities affecting the normal and orderly sequence by which a wound heals. The day diabetes is diagnosed, every diabetic lower extremity is at risk, and preventative care and education must be initiated. We must educate all healthcare providers, patients, and families, the evidence-based guidelines which have been proven cost-effective for the overall function and well-being of our diabetic patients. We must also identify diabetic patients at higher risk for developing lower extremity ulceration. Having trained at the Joslin Diabetes Center and Deaconess Hospital, I have been extremely fortunate to be part of a team approach to the prevention and treatment of diabetic lower extremity problems. Diabetics can lead normal lives within the parameters of their disease. First and foremost is adhering to the best evidence-based medical treatment. Diabetic patients must understand in simple terms the triopathy of their disease and take ownership of their feet. Shoeing is a leading source of emotional and physical problems as diabetics want to look and feel normal, and let's face it, shoe appearance tends to supersede comfort and fit. As simple as it sounds, diabetics should rotate their shoes and socks 2 to 3 times a day, which relieves the stress points and provides time for self-inspection. For women, the pointed high heels may be okay for an hour or two, but because of neuropathy, repetitive high stress is a source for early ulceration. Running in walking shoes fitted properly are socially acceptable and a great addition for part of the day, and especially for any kind of lower extremity exercise such as walking or running. Diabetics with peripheral vascular disease need supervised exercise and added neurovascular protection. Remember that because of the predilection for atherosclerotic tibial peroneal artery disease, diabetic patients may describe foot claudication or pain and not typical calf or thigh claudication. Avoid the same repetitive stress on the feet, which is why we prefer not just exercising on a treadmill, but on a varied terrain. Never soak feet in hot water or astringents of any kind, as the heat or chemicals may burn insensitive feet, especially in patients with autonomic dysfunction as well. Avoid extremes of temperature and conditions for the same reason, and that means no bare feet. And finally, diabetics must know you are interested in their well-being, and they should immediately report any problem or concern to you. Living what we consider a normal life is possible for most diabetic people, even those with peripheral vascular disease, as long as the guiding principles of preventative care are an essential component of their daily routine. Amputation remains the diabetic's greatest fear, and education, communication, and simple preventative steps are priceless.
This briefing is made possible by a grant from Cook Medical. To learn more about vascular health, visit vascularweb.org.